During the decade U.S. troops fought in the Vietnam War, 361 Utah soldiers lost their lives. In 2017 alone, nearly twice that many Utahns died from drug overdoses, most traced to opioid use. They are casualties in a national health crisis where any Utahn filling a pain prescription can find themselves at risk. Today on Ask 11, we seek your input during a discussion of Utah's opioid crisis.
Good evening and welcome to Ask 11. I'm Rebecca Cressman. Tonight we've assembled a panel of those who face Utah's opioid crisis daily. They're here, though, to take your questions about how the crisis impacts the state and how Utahns are best able to respond to it. Our guests include Angela Stander from the Utah Department of Health. She's the Prescription Drug Overdose Prevention Coordinator. Alema Harrington, a licensed substance use disorder counselor, and he also serves as a board member for Utah Support Advocates for Recovery Awareness, or USARA for short. Jim Winder, he's the Chief of Police in Moab, Utah, and of course, the former Salt Lake County Sheriff. We welcome you as well. And Representative Ray Ward, he was elected from District 19 in the Utah House. That's the Bountiful area. He's also a physician who practices in Davis County. So glad that you're here. Now, we're anxious to hear from you. What do you need to know about opioids? Have you had experience with addiction? And how have you dealt with it? It's when we as a community open up and discuss the issues opioids present that a path forward opens up for us. The ways to reach us are at the bottom of your screen. You can send us a text message at 385-312-0275. Our email address is ask11@byu.edu. Or you can send a question through social media on Facebook and Twitter. Just use the handle at KBYU11. So first off, let's talk in general about what are opioids. And Angela, would you want to start kind of with a description of, we hear a lot about opioids, so what are they?
Yeah, we do hear a lot about opioids, and we actually know through focus groups that most Utahns, of course, now know that opioids are dangerous. When they hear that word, they cringe, and they know that it should be alarming, but a lot of them don't know what the common opioids are. And so most commonly you're prescribed an opioid after surgery or maybe a dental procedure. Some of the common brand names that you're usually taking home are Vicodin, Percocet, Lortab, OxyContin, generics such as oxycodone, hydrocodone. And a lot of times people don't realize that they have these in their cupboards already, or that they're frequently taking them home from the pharmacy, that they're frequently being prescribed these.
And as a physician, you've noted, have we seen a rise in prescriptions for opioids over the years, and has that contributed to the amount of opioids we're seeing in our community?
This problem started about 20 years ago, when, because of some government rules and some beliefs, the number of opioid prescriptions went up by a factor of 5. Wow. So 5 times as many, and that happened between about 1996 and 2002. And the number of overdose deaths went up by a factor of 5, wow. And we've been stuck at that high level ever since.
And Utah is ranked at number 7 in the nation, so that's why we're calling this a crisis for the state of Utah.
Yes, we remain in the top 10. We kind of fluctuate between 4th and 7th, but usually anytime we do go down, it's not necessarily that we're improving, but other states are joining us in the ranks.
Okay, we appreciate it. We already have a question on Facebook, so let's take a look at that. Do we have any data on how many opioid deaths happen to those who have legitimate prescriptions versus those who obtain pills from a third party? So again, trying to understand who's maybe at greater risk from the use of opioids. So do we have any data on how many opioid deaths happen to those who have legitimate prescriptions versus those who are obtaining it from a third party?
Yeah, those numbers are kind of hard to gather. We are able to tell when an opioid death is either from an illicit drug such as heroin or from a prescribed opioid, but it's hard to know if they were given that prescription. We do know a statistic that 70% of Utahns who've misused or abused opioids have stated that they got them from a family member or friend, so that's a good indicator that access is a big thing. A lot of times they aren't necessarily the person's prescriptions, but maybe mom or dad's or grandma's. They're very accessible.
And we may not be considering that person as a third party. It's a family member, so it seems somewhat safe. And I know, Alema, you've worked very hard to try to educate about how important it is for us to be aware of what we have in our house and the dangers that lies.
Well, I think, just to add to what the doctor has already stated, which is about 20 years ago when the prescriptions changed, it was this, I think this, an honorable desire to treat pain, but not being aware as we are today of the dangers that opioids presented. For example, when I was here at BYU many years ago in the 80s, the prescribing protocol was very different than I think the direction that we're heading, Doc, and you can address that. And I think we're heading in the right direction because we have a better understanding of the dangers of opioids and the possibility, more of a probability, really, of becoming addicted.
And so, from your point of view as a member of law enforcement, have you also seen a rise in either criminality associated with opioid use?
Absolutely. Addiction is a very complicated subject, and the question also, presented made me think that people believe oftentimes that overdose is a linear prospect. In other words, they will have one particular substance that they take that causes the particular problem. From a law enforcement perspective, people use illicit substances for so many different reasons, and oftentimes they will use anything they can get a hold of. Clearly, opioids might be their primary issue, but you have to remember that they will also use other forms of both illicit and legal drugs on a regular basis, and those kinds of cocktails, so to speak, are exceptionally dangerous. And they, of course, lead to a host of other criminality and sociological issues that we in law enforcement end up really dealing with. And as far as the uptick, the statistics that the doctor and Alema have alluded to, everybody has, we've seen it exponentially in our jails and prisons. As you know, Salt Lake County Jail, which I managed for many years, bursting at the seams, aggravated dramatically by the uptick in opioid use.
All right. Now, of course, we want to hear more of your questions so that we can field them for you. You can reach out to us through ask11@byu.edu. We also have a text number on the screen that you can text us your questions. If you would like to reach us through any of our social media, you're welcome to use that at KBYU11. We just want to hear from you to make sure that we're giving you the information that you need. I keep thinking about that last question where the viewer was thinking about, that which is legally prescribed and that which is coming from a third party. So help us. Let's talk a bit. What should our mindset be in general? Should we be thinking about what we're legally getting, what we're not legally getting, or what, from your perspective, Dr. Ward, would you think is the healthier way of viewing opioids?
I think the very fact that someone asked that question means that they still are thinking, oh, if this is prescribed, it's safe. And if it's the person's fault because they're going around the system, then that's their fault because they went around the system. And the thing that everybody needs to understand is they're equally addicting. Whether the doctor gave it to you or whether you bought it from a friend, the biology's the same. If you take that pill for a given length of time, even if you took it exactly how the doctor prescribed, you will have horrible withdrawal when you try and stop it.
And I'm so glad the doctor raised that. People think that maybe that people are using these to recreate. The reality is the majority of time what they're doing is to stave off these hideous symptoms, and they'll do almost anything to do that, whether it is obtain it legally, whether it is to find it from a relative, whether it's to go on the street. And so this idea that when they may overdose, that it is just because of the prescription medications they might have. It comes from a variety of different sources, and this is such a complicated issue in terms of what motivates people to continue to use these substances.
I appreciate that perspective, Chief, because I think what we're talking about, which I can speak to specifically as a person in long-term recovery that has been addicted to very powerful, to opiates and to heroin. When you're talking, Chief, about to stave off withdrawal, this drive that the addict has to not go through withdrawal is very powerful. And it operates in a part of the brain that is very powerful as well when we're talking about the acute symptoms of being in addiction at the moment. And so that drive is the drive that is like, I can't get sick. And so because of that, I'm willing to sacrifice those things that I care about dearly, including my family, my values, and all of those things so I can get what I need so I'm not going to get sick.
So what begins
Yeah.
as a desire to stave off pain becomes a compulsive behavior just to try to feel well on a regular basis.
So it's not really, by the time you get in too deep, it's not just to stave off pain, although that's part of it. It is to stave off withdrawal,
Okay.
which is pain plus a lot of other very difficult, compelling symptoms.
And before we take a Facebook question, earlier you had mentioned something. I wanted to share it. How many days, at approximately how many days can a person actually become dependent on an opioid?
Yeah, so I'm glad you gave me the chance to say that, because I wish everyone, doctor, patient, everyone would keep these numbers in mind. If you take narcotics for 10 days in a row, prescribed by a doctor or not, you have a 10% chance you won't be able to get off.
So that's stunning. And
if
that's
you
biology.
Take them, that's
Right.
biology. And if you take them 30 days in a row, you have a 30% chance you won't be able to get off. So keep those numbers in mind.
It's a formidable opponent. Let's go to this question right here, and I appreciate that, Dr. Ward. Here's a question on Facebook, and keep your questions coming in. You can use the handle at KBYU11, both on Twitter and on Facebook. It is difficult to watch as many addicts are put in jail, especially when they are close relatives or friends. Is there another solution that Utah has in mind to help these individuals? My son was lucky. Many others are not. So I'm going to naturally go to you first. So what are some of our options rather than jailing someone who has an opioid addiction?
I think the question is one I have received so many times. Honestly, it is so painful. And having individuals in my own family who have also gone through this, the fear oftentimes and the stigma that comes from going to jail and that kind of perception. I will be perfectly honest with you that sometimes jail is the best option and often the first option that has to occur. Individuals that are suffering from an addiction, that being driven along the lines that we have just talked about, where they will do almost anything. They look past their children and their loved ones and their employers and everything else. To see them come into jail in the state that they come in, and then to see them after they have been through this absolutely horrendous 5 to 7 day withdrawal period, and then to go down and look at them and you can see the spark back in their eyes. They are the person who they always are. But jail has given them the chance to absolutely to detoxify. And unfortunately in the state of Utah, we do not have, in many instances, public accommodations that allow that. If you have money, you can oftentimes go into a treatment program. Those without the resources, however, are left to their own vices. And so jail often is the first and best choice, but it is not the right place to keep them. And it is not the right place to try and address the addiction and the other associated issues. So the question is very sophisticated and very intuitive. But jail should not be viewed, especially if the jail is managed appropriately, in my opinion, should not be viewed as something to avoid at all costs. It should be part of the treatment regimen that is in a reasonable society.
And I want to talk about treatment in just a bit, because that's so important for us to understand that facet of opioid misuse. Here's a text question that we just received, and for those who would like to bring us your questions, a great anonymous way to do it or confidential. Our text number is 385-312-0275. We have one right now. How much responsibility do doctors have for the opioid epidemic? Gee, we have a doctor here on the panel. So, any strong, passionate feelings about the role physicians have played in the opioid epidemic?
Most of it.
Yeah, okay.
This problem came over a 5-year period of time when the number of prescriptions that we wrote went up by that much. It's letting a tiger out of the box. It starts with the prescription, but it doesn't always stay there. The overdose death often isn't from the pills. By then it may be from heroin. My opinion is that doctors, not malevolently, but because we didn't have the information, haven't been honest about how risky it is. We believed honestly that they were safe and effective, and who wouldn't write something that was safe and effective for their suffering patients? But neither of those things is true. They are not safe, and for chronic pain, they are not effective, and we won't get out of it until our habits change back to how they were before.
Now, Angela, I say you're at the Department of Health. This has been part of your awareness campaign.
I think it's important, too, to understand. I mean, we can't put all the blame on the doctors as well. We've become a society who expects a pill for everything. We expect zero pain anytime we have any type of procedure, and we've started to ask for them. So a lot of our public awareness efforts have been to try and empower patients and say, you got to meet them halfway. We can't fully expect doctors to change their prescribing habits, especially if they're going to have patient backlash, if they're going to have an upset patient with them who's going to give them a poor review because they didn't treat their pain sufficiently when really they were looking out for that patient, trying to prevent these risks of opioid dependence or addiction. So really we need to become a society who meets the doctor halfway and who starts that conversation and realize that we can start that conversation. Sometimes I think what doctor knows best, and if he hands you a script, then you fill it. But it's okay to have that, to bring something up and say, hey, I've heard a lot about this. Is there another option? Is there an alternative? And starting that conversation, I guarantee the doctor on the other end will be thrilled that the patient started that conversation, but I think we got to start there too. And the public's got to meet the physicians halfway and not asking this and understanding the risks.
And I don't think we knew. I mean, I'll just speak from my experience. I did not know. I assumed that if a doctor could prescribe me something that would be helpful for me, then therefore it's safe for me to take. And that's, so now we're learning it's not so. Alema, go ahead.
No, I'd follow up on what Angela and Doctor, what you just stated, which is, there's some responsibility certainly in the medical community, but we have become a society that does not want to feel pain. And I can speak from my own personal experience, having gone through surgeries and almost, to a point where you're almost hoping that you have a surgery so you have more excuses or reasons to be chronically on this medication. And I've been in pain clinics over the years. I have a fusion at my L4-5 in my lower back from a football injury here at BYU. But this idea that we need those medicines, right, for a long period of time is inaccurate. And we've finally, I think, come to terms with that. We're 10 days, 10%, 30 days, 30%. These are relatively new numbers, at least as far as I understand it. And so in my recovery today in sobriety, I've had to go through surgeries, and I have a specific protocol that is no pain meds when I leave the hospital. And in my mind, thinking like, oh, this is going to be impossible to manage this pain. But the truth is, we are very capable as human beings of being able to handle that pain. And opiates are specifically for the acute pain at the very onset, and then we're able to manage that very well as human beings after that. And I think that's part of the message I think that we share with our society that has become a pill for every ill type of society.
If I could just add on to that, and I'm going to get a little out of my lane here, but hearkening back to managing a jail where we processed 40,000 people a year through there. The Sully County Jail was one of the largest indigent healthcare providers in the state of Utah, and there's a reason for that, because the healthcare system in general in the United States has many, many deficiencies. And one of the pressures that physicians face too is this idea of the absolute, I can see a patient for 5 minutes. We do not fund our medical treatment. Our healthcare system in general is atrocious. And what I would see oftentimes, individuals who would be on the fringes of society anyway, the lowest rung on the socioeconomic ladder, and one medical issue would spiral them down into oblivion. And that created all these other criminogenic factors. That's the term of art here, where suddenly they're out of work and they have all these other issues. That relates to the depression and many of these other issues that when we talk about pain, it is not just always physical pain.
Sure.
And so the healthcare system in the country has never, in my opinion, over the last 20 years, when do you go into a doctor and spend
45 minutes.
That's right. Where the doctor is saying to you, Alema, what are we going to do about that, and what are your alternatives, and spending that quality time. Do doctors want to do that? Of course they do.
And I think there's been some initiatives saying we need to make sure that our family practice physicians have time to also take a look at the psychological well-being of our patients as well. That is something that I've been seeing over the last couple of years. I appreciate that thought as well. Let's take a text question that just came in. Do people die from taking too many opioids at once, or does it build up in the body over time? So this is a chemical question.
The first one.
Yeah.
So when you build, it's from taking too much at once. If you take a steady amount, you can build up to very high levels and it won't kill you. The problem is if on one given day, accidentally you take too much, maybe you had a particular bad day or that batch of heroin was stronger than you thought. And the way it kills you, it's not like cyanide or arsenic. It doesn't poison you. It just puts you to sleep enough that you stop breathing. And so if you take just that much, that you're that deep asleep, you stop breathing, and that's the end of you.
So the lungs are no longer functioning, they cannot.
The brain doesn't send the signal to breathe, you've just gone to sleep that much.
I think it's important to understand too, because when we're talking about this overdose epidemic that we're dealing with, a lot of times, and we've seen this with celebrities that have gotten clean and then there's an overdose death. And oftentimes it's somebody, because as Doc was mentioning, you build up a tolerance. Like if you look at the amount of opiates that I was taking at the end of my addiction, I mean, it was enough
It would be
to
lethal
kill a
right
horse,
now, sure.
Right? But because my tolerance had built up to that point, you know, I was taking that amount. Now you get clean, and then if we're not treating the addiction from a psychological standpoint, then, and you return to the addiction, in your brain you're thinking, well, I can just take what I was taking before. That will kill you.
Wow.
That will kill you. And oftentimes we see the overdose that happens because of that.
And this, to exactly the point, we would have individuals that would come into jail, they would get clean.
Yes.
And here was the thing that broke my heart the most. Individual would be walking out and they would say, what's my next step? And we'd say, in 90 days, show up for this treatment program, because that's what the waiting list
And
is.
those 90
Who can wait 90 days? Instead, what happens is they walk out of there, and because of exactly what Lemma just said, they've had this terrible opioid addiction. They've been clean for a while, so now their tolerances are much lower. They go out and they party, or they fall off the wagon, or whatever term you want to use, and that is when the risk of overdose death is very heightened. Where is the continuum of care?
Well, and of course, you're the experts, but I'm also thinking about mixing medications as well as a concern.
So let me tell you a story.
Sure, please do.
You could tell hundreds of this story. A gentleman who had a narcotic problem, and he was going to a methadone clinic. And I got involved to sit on kind of on a malpractice case about this, is how I heard this story.
Okay.
And he was at the methadone clinic, but then he had a parking ticket he didn't pay, so he got thrown in jail for 50 days. Gets off, goes through the withdrawal, comes out, goes back to the methadone clinic and says, I need to be back on the methadone.
Sure.
And they just jumped his dose up faster than they should have. And he also got a sleeping pill from another doctor. And on the 4th day, not taking any street drugs, he died. He went home, laid down on his couch. This is a father with young children, but jumping a little too fast, plus a sleeping pill was enough, and that was the end of him.
That potent, that dangerous,
Yep.
that important for us to understand. We also have, I believe this came in by email, a question. Feel free to keep your questions going. We're going to be here throughout the hour with these experts fielding your questions. So here's the latest. Is there an effort to coordinate evidence-based treatment across the state to make outcomes more successful? Many of these programs have a low success rate and high rates of relapse. I'm going to read that again. Is there an effort to coordinate evidence-based treatment, so treatment that is successful across the state versus programs that may not have had a high success? Angela, I haven't heard from you for a little bit. So tell me what your thoughts when you read that question in terms of the efforts the state is making to try to make sure that we have successful programs available.
Yeah, you know, and publicly, Sheriff Winder mentioned it. Publicly funded treatment is hard to come by. It really is. So it's easy to say, don't put them in jail, throw them in treatment, but it's really hard. There's a really big gap in access to treatment here. And when we do have treatment, we do anything state funded, we definitely try and make sure that it's evidence-based, it's covering good things. Private treatment is getting kind of tricky, and some of those kind of go in their own way, but there's been great legislators this last session who've really tightened up the screws there and tried to make sure that the programs that are functioning, that we are sending people to, that they're functioning appropriately, that they're using evidence-based methods, things such as that. But we do continue to see a challenge in providing great treatment.
What would be, like in my mind, I'm thinking, how would I find a resource for my loved one that I know is using the best treatment possible? So you're in the rural areas. I'm sure you're concerned about that.
Well, in the rural areas, the dearth of options is nothing short of, I just can't even find a term it's depressing. The treatment in the Wasatch Front there's a lot of it, but there is such a volume of people that need it. But as soon as you get off the Wasatch Front, the opportunities to get to and from, to have the money to do it, to have the connections, it just is almost non-existent. But what I wanted to just say is, you know, we went through this period of time in the state of Utah with the Justice Reinvestment Initiative, and the entire focus of that was supposed to be to take monies out of the criminal justice system as it was, which is in large measure broken, and put it into some treatment options and be able to identify how to manage that. From my standpoint, That hasn't necessarily moved forward with the kind of vigor that we could. Doesn't mean the legislature has not been moving in some ways, but we have got to get these treatment options that are evidence-based in the rural areas and recognize that if everybody concentrates in Salt Lake County and Davis County and Weaver County, that's where the problems are going to be most acute, and it's going to be a failure. We've got to start getting it out into the areas that are state funded.
And before I talk to you, Alema, because I know this is something that you're very familiar with, can we just clarify, Chief Winder, do we have serious drug misuse issues in the rural areas as we are seeing in some of our populated areas? Is there, because we have the myth that it's open fields and ranching and clean living.
Yeah, it's a myth. Doesn't mean that there aren't wonderful, tremendous folks in rural Utah. My experience, and the doctor and I were just talking about that in Grand County in particular, our situation is less acute, but if you go into Carbon and Emory, the statistics in Carbon County are mind-boggling. And you go up into the basin, go up into Vernal and Duchesne and areas like that, you know, the methamphetamine and the opioid abuse situations are very problematic with nowhere to go.
Okay, that's why we're talking about.
Let me just, just to back up what the chief is saying here. I was just at a round table that was up at the Attorney General's office with representatives from Washington, D.C., and the Future Farmers of America were represented there because they're dealing with this with their population. So to speak specifically to that, on the other topic, which is treatment, the thing that we do know, evidence-based is an interesting thing because you're always waiting for the evidence to come out and
what works, right?
What we do know is this, that continuum of care is critical to success. We're dealing with a disease that is chronic, progressive, and fatal. We need a long continuum of care to go from residential down to partial hospitalization to intensive outpatient to general outpatient. There's lots of things that need to take place so that we can continue to treat the disease as people are finding recovery. So there's plenty of debate on what is successful and what is evidence-based and what works. What we do know is let's try to keep them engaged in the treatment process for as long as possible.
And it has to be holistic. If you're dealing solely with the idea that the substance itself is the only issue, that is mythological. You have to deal with the associations, you have to deal with their work, you have to deal with their family issues, you've got to deal with their self-esteem, all of these kinds of factors to just say, as long as you keep them away from the dope, they're going to be fine.
Right, and when you say holistic, I mean, some of the information that I had been reading was the importance of teaching us as patients, as individuals, is coping mechanisms that are healthier for us when we are feeling not just withdrawal, but whatever might also be triggering our desire to not feel something, and learning those healthy behaviors as well.
Yeah, and resiliency training as well. I think people want us to teach a lot the youth and want us to go in and tell them, simply don't do drugs, drugs are bad, but really what they need is to learn how to cope, learn how to deal with stressors, resiliency training so that they don't turn to these different things.
Can I ask you, Dr. Ward, I love that you're a legislator, and I love that you're a family practice physician. Help us understand kind of what's happening in the human body that makes it so difficult to just stop. We talked about the withdrawals, but when we're saying it may take much longer for a person to be able to become free of their addiction, is it all about chemical dependency? Or
these substances are the most addicting substances we have ever discovered, right? You can make a list of how addicting something is, and these are at the top. I think those of us who haven't been in that situation can't pretend to understand how difficult it is. There's this period at first where it's all day, every day, very intense, and then people get through that and they go out to some longer period of time, but something triggers them. Their girlfriend breaks up from them the same day they crash their car, and today they're in a crisis, and they know that they could feel better today by relapsing back, and that's enough to send them back from whence it is very difficult once again to get back out from that small trigger.
For those of you who have questions on the top of your mind that you'd like to send our way, we have time, another half hour or so, where we will be answering your questions. We have a text number that is on the screen that you can call and text actually at any time. So please give us that text. We'd love to answer any of your questions by email. That's ask11@kbyu.edu. And our discussion is involving Utah's opioid crisis. It will continue in a few moments. Thank you. And welcome back to Ask 11. Tonight, we're getting your questions and concerns about Utah's opioid crisis. During the break, Alema Harrington from USARA left our panel. We're now joined by Dr. Robert Simpson. He's also a USARA board member and a board-certified physician in addiction medicine. So welcome, Dr. Simpson. It's a perfect time for you to be coming in because we were just asking a question about how do people find evidence-based treatment for their loved ones. What are your thoughts?
So I think that there are a number of things. One of the most important evidence-based practices that is dramatically underutilized is medication-assisted treatment. And there are a variety of medication-assisted treatments for other substance use disorders, but with specific respect to opioid use disorder, methadone, buprenorphine, and naltrexone are three medications that are highly effective in this population.
How do they work?
They work by binding to opioid receptors, either in a way that stimulates them, partially stimulates them, or altogether blocks them. And in doing so, they reduce craving in the person who has the disorder. All three of those medications, when applied appropriately, have been shown to dramatically reduce overdose risk, dramatically increase retention in treatment, dramatically reduce contraction of hepatitis C and HIV, reduce recidivism and reincarceration, and help people get restored to lives of meaning and purpose, which is, in general terms, what we're looking for in recovery.
Do we look at that type of medication as a bridge to sobriety?
So I want to be careful with the terminology here. I regard people who are on those medications who are under the care of a physician or a practitioner who is prescribing responsibly to be in sobriety and in recovery. All too often I hear people say, you know, I'm clean other than I'm taking buprenorphine. And I think that that's a mistake. These folks are in a recovery process, and that's the name of the game for us, is how do we keep people in a recovery process? Now, is it a bridge? In some cases it is. It's not necessarily a lifelong commitment to these medications. Sometimes they're used on a short-term basis, others on a more intermediate-term basis, and still others on a more chronic basis. I think one of the important things in terms of evaluating evidence-based care is that it needs to be particularly designed for the individual. Everybody is different. I think that people's pathways to addiction are different, people's genetic loading for addiction are different, people's risk factors and resilience factors are different, and this all has to be taken into consideration when formulating an effective treatment plan.
As you bring up a number of those medications, it brought me to, and I hope that I pronounce this correct, and it's not the same use of medications, but we are seeing in order to save lives of individuals who have overdosed on opioids, is it naloxone?
Yeah.
Okay, and we are seeing that throughout the community, trying to make sure that it's available. Who is the best to talk to me a little bit about what the role of naloxone?
Yeah, naloxone is important. Naloxone is an opioid, an antidote to an opioid overdose. So as Dr. Ward mentioned, when you overdose on opioid, you flooded those receptors and it's caused respiratory depression. What that does is goes into the brain, the naloxone knocks those opioids off and gets the person breathing again. So it's a safe medication. There's no abuse potential. Someone can't misuse it. If you use it on someone and they're not overdosing, there's no negative response to that. So really, what it does is kind of bridge that gap of the time for first responders to get there. And so what we've tried to do a lot in our state, and the reason we've seen it around a lot more, is we're starting to understand that the first responder usually is a family member or friend, and there's a really small window of time when you can reverse an opioid overdose. A very small window, and that time is crucial. So in promoting naloxone, we want really those who have family members or friends who are on high doses of opioids for chronic pain who use it appropriately, and also those who know that their family members or friends are addicted and misusing it, that they have naloxone on hand, because it's simple to administer. It's either through an IM muscular injection, or there's also a simple nasal spray. So it's very, very simple, and so we've increased access so that more people have it and can use it.
So the medications that you were listing, Dr. Simpson, these were medications that are being used under the care of a practicing physician to help that person in sobriety or working towards recovery,
Yes.
to be able to manage that sobriety. Naloxone is for crisis. At that point, we need to be able to use this to be able to save a life. And you're seeing, as Chief of Police in Moab, you are seeing now members of law enforcement carrying naloxone and dispensing it on a regular basis.
We are, but I want to just make a comment about that, because what the doctor just said about it being it has to be multifaceted, and every person is unique. Some departments are refusing to use naloxone because of this perception that somehow it promotes narcotics use, or that it enables. One has to realize that these people, as we said at the beginning of this discussion, these people are not, it's not that they're enjoying this activity. You can't treat someone if they're dead. And the whole objective in law enforcement, and I would encourage every agency in the state to, we do in Moab, we did in the Unified Police Department, Salt Lake County Sheriff's Office, and I hope every agency would. You've got to be able to get these people through these very difficult times and get them back into this treatment regime. It's a lifetime issue, this addiction.
Yeah, I mean, goal number one with treating this disease is nobody dies.
That's it.
Right. From there, we can work on all of the other facets, but once people are dead, it's done. And just to build on what Sheriff Winder had to say, or Chief Winder these days.
It's okay.
Yeah.
He goes by lots of titles now.
Jim works fine.
This is shocking, but I have pharmacies in Utah County that will not fill naloxone. I have pharmacies in Utah and Salt Lake County that I can't get to provide buprenorphine in timely fashion. There is such stigma around this disease, and we really have to move beyond the idea that addiction is a moral failing, is a lack of willpower, is just poor behavior by people who can't control themselves, to the idea that this is a disease that needs to be treated compassionately.
I saw you react to that, and as a physician, worried that it's not available in pharmacies. Did that shock you, Dr. Ward?
I guess I have had most of my patients be able to get it from pharmacies fairly easily.
Can we talk about how to get it?
Yes, please
Let's
do.
mention real quick how to get it. So through a standing order, you can get it at any pharmacy, not necessarily over the counter, but now you no longer need a prescription from your physician. So if hopefully the pharmacist, and I'd like to track down that pharmacy and do some education.
After the show, you'll be able to talk about that.
But majority
yeah.
of pharmacies we are seeing are willing to prescribe, and so you can pick it up. It is very affordable, $25 to $50 with insurance, and if money is an issue, there's a lot of local community-based organizations who do give it out for free. So there is a way to do it. You can call the health department. We can find you some, but do go to your local pharmacy, and you are able to obtain it without a prescription from your physician.
So I'm going to present myself. Let's say I'm a mother of a daughter or a son, and I am concerned. I realize that my child has been dealing with an addiction for many years. I hear about this. I can literally walk myself up to a pharmacy and say, I want a prescription for naloxone.
Absolutely, naloxone. And if that doesn't work, go to the next one, because I know that majority are handing it out.
And the Utah legislature did a wonderful thing in the city of Moab or in other jurisdictions. If our officers go in there in exactly the situation you just described, our officers can hand them the naloxone that we have in our possession, and there's no barrier to that. And we encourage that for the very reasons, because oftentimes that first point of contact to say, look, you've just discovered that your son, daughter has this particular issue. You're at great risk right now. Go ahead and take this. And it's worked out very well. So
now, if I have an addiction myself, should I be carrying naloxone?
You should. You can't necessarily administer it on yourself, but if you are, you should be carrying it, but let people know. Let your loved ones know, hey, I have this. This is where I keep it. so they know it's available.
Absolutely. And if you have the disease of addiction, it's likely you're hanging out with other people who do too.
Okay.
So it may well be that you get to save somebody else's life with it. So anyone in my clinic who has a diagnosis of opiate use disorder gets a prescription, not that they actually need that.
You mentioned that there is a shame that comes as a part of addiction, whether or not it's someone in your family you're concerned, maybe you're feeling also shame about, loved one that you have, maybe it's your own personal shame. I'm wondering, as a physician, are you getting people confidentially asking you questions about loved ones they're concerned about? Like where's our front line when we are concerned? Where do we first go if I'm worried about my spouse, if I'm worried about my child? Who do I safely, confidentially reach out and ask those questions to?
I think every physician probably has questions about it because it's such a common problem, and I hope physicians are learning to talk about it more as a disease, more with compassion, more to say, these are the things that either I can do to help you, or if you're a primary care doctor who doesn't do Suboxone, primary care doctor's job always is to get that person to someone who can help them with the problem. It gets tricky because they're always, the addiction is such a powerful thing that even if we do, I think correctly say it's a disease, not a moral failing, but it is such a powerful thing that for many people it leads them to other crime. If they get to where they've lost their job and the only way they have now to make money is to sell the heroin, now even if you said the use is not a crime, now they've still crossed that line, or to steal to support their habit. So it shades off into all these other crimes and behaviors that are not the addiction itself, but they're associated with it, that are really difficult and are going to land you in jail one way or the other, even if we don't call the addiction itself a crime.
I think one of the tools that's very powerful that we're trying to get instituted more and more in the community is screening, brief intervention, and referral for treatment. And that is essentially just what it sounds like. There are a few simple screening tools for substance use disorder. The responses to those questions lead to then almost a scripted discussion with the patient about, I see how you've responded to these questions. Would you mind if we just talked a little bit? And if there appears to be something which rises to the level of substance use disorder, referral to treatment, so that if that particular provider is not comfortable with providing those services, that they're able to link their patient with somebody who is.
If treatment is available.
And this is the difficulty in so many of the rural counties.
Even in the larger ones, in the jails in the state of Utah, we've been doing a screening mechanism for some time, and yet we have not seen the commensurate increase in treatment options as a result of those diagnostic tools. So the reason I say this is, elephant in the state,
Right.
The expansion of Medicaid, without people beginning to realize that this is going to cost us money one way or the other. And if you want to spend the money on the jails, you go right ahead and it'll just be a revolving door, or you can spend less money in a much more effective way and increase and bolster the treatment, and that's what we need to be focusing on.
Yeah.
It's a dramatic difference, isn't it? The
Dramatic.
cost to be able to support prevention and treatment.
It's huge. So prevention, we know that every dollar that gets spent on prevention will save $40 in medical services, criminal justice services, social services. It's a tremendous investment. We also know that 10 to 12, perhaps 15% prevalence rate of substance use disorders in the population. So we've got, 3 million folks in Utah, so, we're talking about 300,000 people. We've got something on the order of 30 addiction docs. I think that there are about 150 docs who have a waiver to provide buprenorphine. So if you do the math,
It doesn't add up.
the resources just don't exist. But the other part of the problem is that even treatment centers that do exist, many of them refuse to embrace medication-assisted treatment. People are leaving the 30, 60, 90-day treatment centers and medication-assisted treatment isn't brought up. So there really needs to be a movement that insurers insist that if our patients go to your treatment center, this will be part of their ongoing treatment plan. Again,
Comprehensive care.
this is a chronic disease. It's not a broken leg. You're not going to leave treatment cured. Treatment puts the disease in remission. Ongoing chronic care is what keeps people in remission.
I appreciate that because that changes the paradigm of how we think of it. So appreciate that, Dr. Simpson. We have a question, and this one is, what pretrial options are available to prevent first-time offenders from going to jail? So we'll step back into that. What pretrial options are available to prevent first-time offenders? Are we talking drug court or?
Drug court is the classic. The Utah legislature has also engaged in an initiative through the Justice Reinvestment in what they call sentence deflation. The concept there is to take what were felonious drug crimes, possession predominantly, and move those down into more minor levels. The theory being that if individual wasn't stigmatized through a felony conviction and had the opportunity to divert at these lower levels, that would assist. Again, predicated on if they were diverted at the lower level, they wouldn't go to jail, they'd go to treatment. Drug court, highly effective, especially if it adheres to evidence-based components. There is some variables in the state. We have some drug courts that have kind of reinvented the wheel and are not so efficacious. But the other thing I just want to mention to people is sometimes people will avoid, again, getting their loved ones involved in the criminal justice system. Oftentimes what we find is the high rates of participation are predicated on, unfortunately, the leverage of the court. It does work in tandem and can work very effectively, especially when you're in a very, very acute situation. And I would encourage people to not be totally opposed to involving the criminal justice system. It's not the best option in some cases. It's also not the worst.
Right.
Yeah.
Appreciate that clarification because it seems that would be one of the scariest things is
Very.
to have a loved one going in through the court system. We have another text. We appreciate we have time to take some of your texts as well as your emails, and we'd love to field your questions. This one that just came in. What kinds of plans does the state of Utah have to get the opioid epidemic under control? Now, I know you've also proposed legislation, so let's talk about what are our legislative plans in the state of Utah?
So there are some things that have been done the last couple of years that are in the process of being put into place.
Okay.
So we did not do yet a complete Medicaid expansion. We did a small, partial expansion, but it was targeted to those with substance abuse and mental illness. And we are in the process of enrolling people right now. We're not up to our cap of how many we can enroll, and that will help some. And then we have other plans which may further expand Medicaid this year. There's a ballot initiative that may have enough signatures to be on the ballot, and the legislature also passed another Medicaid expansion, which will still need permission from the Trump administration. But if we get that permission, then more people will have that
access
coverage. That's
to
right.
the care that they need to get.
In addition, both the legislature as well as large healthcare organizations such as Intermountain and others have started taking steps to reduce the number of high-risk prescriptions. We know certain combinations are very risky. Opioids plus benzodiazepines, 6 times the overdose death rate. And to start making those statistics aware back to prescribers, to have insurance companies start saying, well, look, if it's going to be high risk, it's going to require prior authorization. Particularly in my mind, the most important thing is to not get new people addicted. So to be very much more careful with first opioid prescriptions. In my mind, if you're going to write a new prescription, then it's also you need to make sure the person's back off.
And have that honest conversation right at the start. That's why I'm only prescribing you this. I also want to bring you in because, Angela, your role is with the state of Utah as well, the Department of Health. What are we doing as a state to try to help address the opioid epidemic?
Yeah, I would mention kind of a three-prong approach. There's actually a lot more than that, but provider education, reducing our prescribing, and also including an educational component in there. A law just passed this last session which requires pharmacists to put a warning label on prescriptions. So like I said, most Utahns heard about opioids, they're not sure when they receive one. So
And the red label will
requiring-
tell us this is...
Yeah, so it says caution opioid risk for addiction and overdose, and leads them to a website for more information. And they're also required to hand out an educational brochure with that. So educating providers and pharmacists to do more education, continuing to do a public awareness effort, not only warning about the dangers, but also reducing stigma. Messages such as talk about addiction, giving people a voice that really never had a voice, and understood that a lot of people are dealing with the same thing, and that it's okay. And then also efforts to expand treatment and to increase that as well. And then also looking at people who are deep in addiction as people, doing things such as syringe exchange. We won't get too much into that, but things as, okay, we'll meet you where you're at. If abstinence isn't an option right now, there's medication-assisted treatment. Let's keep you safe. Let's keep you from preventing diseases. Things such as providing clean syringes, naloxone, things such as that. So harm reduction and also primary prevention, making sure people don't get addicted in the first place.
I appreciate that. And I keep the statistic Dr. Simpson had shared earlier on about just how prevalent opioid dependency and addiction is in our state, that we should not feel so isolated or alone to talk about it, because if we're dealing it in our household, 5 houses down, someone else is dealing with it, 10 houses down. This is something as a community we should be talking openly about, and working with our government and working with our healthcare providers to make a difference. We have a great question that just came in. Can medical marijuana help to replace opioids? And this has been a part of that conversation. What do you say? Is that fair to ask you, have you answer that question?
That's a complicated question. How long do we have left?
We've got 3.5 minutes. What do you think?
So the answer is I don't know. I think my concern about the marijuana question is hiding marijuana in the medicalization business. I think that if as a community we all vote that we want to smoke weed, and that's what we've decided, and we're going to smoke it recreationally because we think there's some benefits, then that's one thing. But there is very little medical evidence, with a few notable exceptions, that there are benefits to cannabinoids. There is significant risk associated with cannabinoids, particularly in patients who have vulnerability to addiction. I would love to see there be more research done. There may well be cannabinoid derivatives that are effective analgesics, but there is no other medication that we use that we would prescribe, smoke 3 bong rips anytime your leg hurts.
So,
I mean,
I know that you said it requires more information, but the argument or the discussion, the question that legalizing marijuana use would rid our community of opioid
Absolutely
misuse
not.
is not, it's a false equivalently. Okay, thank you. Go ahead.
I believe that.
I think we got to remember how we got into this. Dr. Ward mentioned it, that we thought this was a safe way to treat pain, and what we didn't know has now turned into an epidemic now, and we have to change that paradigm. And I think don't jump to the same thing with marijuana, and let's not find out years later that it has all these backlash.
I love that
effects.
you're saying evidence-based research. Let's make sure that we have the research there. I appreciate that. We have another question that came in through Twitter, and we appreciate that. How can I help my family and friends who are addicted to opioids? And we just have a few more minutes left in the show. This, to me, could be one of the biggest questions that we answer. So can we do that? How can we help my family and friends who I know now are addicted to opioids? Your thoughts?
To seek out medical treatment, to seek out a physician who is skilled at it, and if they need to be inpatient, if it's that deep, then to be inpatient for a while. And I think if it really has been a long-term problem, if they've been on and off and it's gone poorly several times in a row, to come to terms with the idea that the treatment also is going to be long-term. It's not going to be another 1-month treatment. This is the magic treatment, and then it's going to be done. But if you're on that long-term treatment, there's a very good chance that things can go a lot better.
Appreciate that.
And I would just like to say that I think it is critically important to meet people where they are. If somebody is in an addictive process, they may not be at a place where they say, yep, I'm ready to give it all up today. And so then the question becomes, what progress might we make today? What part of this are you willing to have a look at today? it gets to be about relationship building. And over time, if you cultivate relationships with people and meet them where they are consistently and honor that relationship, behavior change happens. But sometimes it's a slow process.
And what I've appreciated by having you all here today is that you've shared such helpful information, because often we're faced with a loved one or family member who is struggling with addiction, and we don't know what paradigms to work from, that there's help, that there's long-term sobriety, or long-term medication that could help with sobriety, that being in jail may not be the worst step. It might be the first step to having comprehensive care. And so there's so much of that we need to gain more education and more information about. So I've appreciated that. And of course, we want to keep more of this information flowing. So thank you so much. Now, we've reached the end of our hour together, and I'm so grateful for the experts who joined us today. Angela Stander from the Utah Department of Health, Dr. Robert Simpson from USARA, Chief Jim Winder, who's come all the way to Provo from Moab, and Representative Ray Ward, who's a legislator and a physician. And earlier tonight, Alema Harrington from the USARA board was our guest. Now, thank you all for your insights tonight and your work in confronting Utah's opioid crisis, because I know in each of your roles it's ongoing. Now, this program will be archived at KBYU 11's YouTube channel. So to find it, search KBYU 11 from the YouTube homepage. And if you have more questions or you need help with an opioid addiction issue, please call 211, or you can visit 211utah.org on the web. It's an information and referral service, and it's provided by the United Way. Thank you for joining us. I'm Rebecca Cressman, and good night.